My name's Catherine. I'm one of the SPs here at Leeds. Can you all hear me okay? Is that all right? Okay, good. I'm also one of the OSCE coordinators for Countdown to Finals, so I hope it's been going well so far. I have to apologise, I've already made one error in that, well, the person that was meant to be here tonight is in Sri Lanka getting married, so I'm here instead. So we're doing Shock and Sepsis, which is actually one of the lecture series rather than the OSCE, but we'll try and make it a bit interactive. I was going to try and bribe you with sweets, but I have to throw near the mic and my throw is absolutely terrible, so it would have just been humiliating. so hopefully you'll chip in and just ask questions as you go. So in terms of what I want you guys to get out of the session is basically understanding what shock is and the different types of shock, and how you go about the initial management, because that's what you'll be doing as F1s. One of the key things is knowing about Septic 6 and Surviving Sepsis campaign, so that's a key area we'll focus on. They're all ACT topics, so it's important for finals. So hemorrhagic shock, shock itself and sepsis are all ACT topics, so you need to know enough about those. And obviously I want to help you guys pass finals, but I think more importantly it's about what you'll be seeing as an F1, and this is something that is really common. So it's a pretty important topic, because as I was saying, it's not just about it being essential for finals. And from what I understand, although I'm not a Leeds student, your guys' finals are really very much geared towards being an F1 and being a safe doctor. And so this will be really important. You will see it as an F1. You will get called to see people on the ward who are in shock or septic. And it's one of those things that you don't want to miss, or you don't want to fail to recognise it, because if you pick it up early, then you can really help improve someone's outcome. I don't want you to look like this. I want it to be one of those things that you get called about, like when someone has an NSTEMI and you have one of those moments of an F1, like, I know exactly what to do here. Because you'll have loads of moments where you're like, I'm not sure, am I doing the right thing? But with shock and sepsis, you should be able to do that initial bit really well. And so hopefully by the end of the lecture you'll be feeling like this, but hopefully a lot younger and fresher and feeling like this. So, does anyone want to tell me what shock is? Or what do you guys understand shock being? Yeah, exactly. Perfect. So, it's, sorry that's come out of the box a bit, but it's inadequate tissue perfusion, and it means you don't get enough oxygen. It's not, there's a common misunderstanding that to be in shock you have to be hypotensive. That's not the case at all, okay? So don't say, oh, this person isn't shocked because their blood pressure's okay, because that's not right. Later their blood pressure might be in their boots. But also, when using things like blood pressure, you've got to remember everyone's different, and someone's normal blood pressure might be 160 systolic. So if it drops to 120, that's quite a drop for them. And in terms of the consequences of shock, it's to do with tissue perfusion. So if you're not perfusing the tissues, then you get tissue hypoxia. And when there isn't oxygen, then you switch to anaerobic metabolism. And if you still don't have oxygen, then you can't get rid of the lactate. You also produce less ATP through anaerobic metabolism. And the end result is lactic acidosis. That's why we measure the lactate in shock. So what sort of features would you expect to see in someone who's shocked? How would you go about diagnosing it? If you were called to see someone on the ward, what sort of things would make you think, oh, I think this person is shocked? Think about vital signs. I know you guys know it. Sorry? Yeah, tachycardia. The thing to remember about tachycardia is if you've got an elderly patient on beta blockers, they're not going to be tachycardic. But yeah, tachycardic, one of the earlier important signs. What else would you be looking at? Even from just the end of the bed, what might you notice? Yeah, exactly. So they might either be behaving confused, they might be drowsy, all those sorts of things. They're going to look unwell, generally, and they might look sweaty. And then when you go to examine them, they might feel cold, they have a reduced urine output, possibly low blood pressure, increased respiratory rate, those sort of things. And it's really a clinical diagnosis. The thing to remember about respiratory rate as well is it's a really early sign of someone not being very well, but actually when it comes down to it, I think things like heart rate and blood pressure are much easier to measure and they're more objective. So sometimes that increased respiratory rate might go unnoticed a little bit initially. And there's things like decreased cap refill, although that's a bit less specific. So you don't really need to memorise this stuff. It's more just to be aware of what can happen in terms of a patient progressing through shock. And it talks about compensated, uncompensated, and pre-terminal. There is terminal shock as well, but that's just made in retrospect if someone dies as a result of shock. And I haven't put exact values here because there's not, if you look at hemorrhage and things like that, you'll see stages of hemorrhage and grades, but shock doesn't really have specific values. But what I'm really getting at is that I want you to be able to recognise the person who's in compensated shock. And often young and fit people, they will compensate for quite some time, and then they'll go off, and they'll go off quite quickly because they've been compensating for so long. And someone who's compensated, they might not be that tachycardic. Sometimes their diastolic pressure will go up or their pulse pressure is reduced to compensate as well. And they'll have a slight increase in respiratory rate. And they might be mildly agitated or confused. And then as you go across to uncompensated and pre-terminal, they become anuric, more significant decreases in blood pressure. And what might be initially a bounding pulse will become weaker and threadier, and they'll become less conscious as it progresses. So a little bit of physiology, not too much. I don't want to take you too much back to your early years, but does anyone remember what makes up cardiac output? Yeah, so heart rate and stroke volume, and then stroke volume is to do with your preload contractility after load. Now, this whole concept might be a little bit simplified in the way I'm going to use it, but what I want you to understand is we're going to talk about the different types of shock and what happens with each type of shock, and how these different things come into play. So we're going to start with hypovolemic shock. So it's loss of volume. So shout out a few things that might cause you to go into hypovolemic shock. Yeah, good. So trauma. Yeah, what might cause you to become dehydrated? Yeah, diarrhea and vomiting as well and things like that. Yeah, that's good. Anyone else got any other suggestions? Yeah, who said that? That's a good one, Burn. Yes. Good. So it's really difficult to see who answers the questions, but thank you. And when it comes to finals, like anything, it's really good to, when you're faced with given questions, particularly in OSCE scenarios, that you can always structure your answers well, so that you can divide it up and sound like you're coming out with logical and sensible answers. So even if things don't come immediately, if you've got surgical sieves and things like that at your fingertips, then you'll come up with a sensible list of things. So you picked out the main ones, so in terms of hemorrhage, and that might be external or internal hemorrhage, and things like AAA ectopics as well, and fluid loss, which you guys got, so that's good. And in terms of what's affected when you've got hypovolemic shock, it's really that you've got that reduced circulating volume, which means you've got lower central venous pressure, you've got less blood going into the right atrium, and you get that reduced stroke volume and cardiac output. And that the rest of your, you compensate by increasing your peripheral resistance by vasoconstricting, and that's why people get colds, because the blood flows obviously diverted away from the skin, so that's why they'll feel cold and poorly perfused. So distributive shock. So this is when you haven't got your vascular control. So instead of constricting, you dilate, and it means that you get reduced systemic resistance and reduced problems that way. So what does, have people got some examples for this? Because this is probably the main area of shock you need to know about, this and hypovolemic. Yeah, so sepsis. Yeah, exactly, anaphylaxis. I think they're the two main ones that, so anaphylaxis, as you guys said, and sepsis, and we'll go into sepsis a bit more later, because that's quite an important one. And then there's also neurogenic shock, which is when you've got reduced sympathetic tone from damage to the central nervous system, and that results in sort of vasodilation and sometimes bradycardia. It's not the same as spinal shock. Spinal shock is when someone becomes areflexive, and reduced reflexes when they get damage to their spinal cord. So it's not the same. And I guess the thing to be aware about is sometimes people get a bit too smart with things like neurogenic. Oh, well, they've become bradycardic, I think it's neurogenic, or that actually could just be a late sign of everything else. And particularly, say you have someone come in with trauma, you would assume that it's blood loss before it's neurogenic. So give them fluids first, don't assume that it's just going to be that. And I guess in distributive, it's all about the total peripheral resistance being reduced, okay, by whatever reason. So in anaphylaxis, you get your IgE effects and mast cells and tryptase, and it causes dilation. In sepsis, you've got all your inflammatory markers, your cytokines, everything else that makes you your vessels dilate, and they also become really leaky, so everything leaks out into the wrong place. So cardiogenic, yeah, MI, yeah, good, valve rupture. Yeah, you're having a great. You've done really well with the sweets, so yeah, that's all really good. You've got most of them. So MI, cardiac failure, cardiomyopathy, valves, bradycardia, overdose and beta blockers, and I guess the thing that's different about cardiogenic is the other types of shocks you'd go for fluids, but in this you don't. In a lot of these you wouldn't want to. So you wouldn't want to be giving someone with in pulmonary edema some fluid because it's going to make them worse. So it's important to be able to kick out this type of shock from the others. And this is all to do with the cardiac output. And what was it for? Is that okay? Sorry. So the slides will all be on website. The final one to mention is dissociative. Now, this is probably less important than the others, and a lot of people won't even mention it, really. They tend to just count the other four. But this is when you can't get oxygen to the tissues, or you can't release oxygen to the tissues. So does anyone have any suggestions as to how that might come about? Yeah, exactly. And things like severe anemia, as well as carbon monoxide poisoning or cyanide. So I think this is quite a good just summary slide. And when you get, if it's something that you struggle to remember, then you can always pin it in your toilet or wherever to help you. And this is just really quickly to go through what we've covered already, and again, don't get too het up by it, but it's just to show that how hypovolemic comes about, really causing the shock, in that you get reduced central venous pressure because of the loss of volume, which in turn reduces your cardiac output because you've reduced your preload, but your peripheral resistance will increase. And whereas distributive is when you've got a problem with the peripheral resistance, so it's dilating instead, which is why you get reduced central venous pressure, or the blood's in the wrong place because of your sepsis and it all leaking everywhere. But initially in that type of shock you often get increased cardiac output unless they've got a problem, unless they've got comorbidities. So initially they'll react to increase their cardiac output by increasing their heart rate and everything else. Whereas cardiogenic and obstructive, they've both got increased central venous pressure, which reduces their cardiac output, and again they don't have a problem with the peripheral resistance. And so when you see someone in shock, this is a really basic diagram, but I guess they kind of split up nicely into two groups really, in terms of, not that you always go on just the JVP, but if it's raised, then you'd be thinking more about cardiogenic and obstructive forms of shock, whereas when it's not raised, you think about sepsis and hypovolemia. And sometimes you might say in trauma situations, someone might be shocked, and you initially think it's due to hemorrhage, so you pile them with loads of fluid and blood, and then if they're not responding as you'd expect, and you have access to fast scans and things like that to check that they don't have tamponade as well, or that you reassess them to check that they haven't suddenly developed a tension pneumothorax and everything else. In terms of the history, it's obviously there's quite a variation in the causes of the different types of shock. And when you're called to see a patient, you'll probably be told a bit about them by the nursing staff anyway. And is everything all right? Yeah. And that will hopefully gear you to what direction you go down. So I guess things like, you'll know if someone's coming into hospital with trauma. Any young female that comes in with abdo pain, you always have to think about ectopics if they're shocked, abdominal pain, AAA as well, and so these are the features to look for if there's any cause for fluid loss like G&D, if there's any suspicion of blood loss, have they had hematemesis, have they got a raised urea on their blood, out of proportion to the creatinine, all those sort of things. Have they got a temperature? If they spike the temperature, then it's normally a good indicator, although things like PE can cause you to be mildly pyrexial as well. And then obviously there's things like chest pain for your MIs, and whether they've had any new medications and allergies and stuff like that for anaphylaxis. As always, your management has to be ABCDE, and I can imagine that you guys, you might get stations in your OSCE where you're expected to recognise someone's in shock, and I think as long as you go through this, and when you're working, as long as you go through that, then you'll be fine. So obviously you need to check the airways patents. In terms of breathing, start oxygen, monitor their sats, check their respirate, check for any chest signs, have they got reduced air entry, have they got crackles. You obviously need to know their BP, their heart rate, to check their CAP refill. You need access, blood. I'm sure you guys know all of this, but obviously an ECG is important, particularly if you think they're in cardiogenic shock, or they might be having an MI, or they might have gone into acute LVF because they've had an MI. and their urine output, have they got a catheter in place? Have they already had their urine output monitored? G is your GCS. Have they got such a reduced level of consciousness that you need to intervene in that way because of their airway? And then exposure, if you haven't found out the cause already, what else can you find? Have they got a rash? Have they lost some blood somewhere? Is there a crack in GVT that makes you think they've developed a PE? And your abdominal exam as well. Obviously, it depends on the type of the cause of shock as to more specific treatments. Like if they've got a massive PE and they're unstable, then they need thrombolysis. If they've got a tension pneumothorax, then you need to get a cannula quick. Anaphylaxis treatment, all those sort of things are a bit more specific, but your general approach should always be the same. I guess the only thing is when you're thinking about C and fluids is to what you think's going on, because if you do think they've got pulmonary edema, don't give them fluids and things like that, but otherwise it's relatively similar thing. One thing to stress, I guess, is especially when you're on the wards next year, is always go back and check your patients. So it's quite easy, you'll get really busy, and you might do all the right things, you might get access, you might have sent off their bloods and done the chest x-ray and be pleased that you've done everything that you needed to do at that point, but you have to go back and check that given that fluid challenge has actually had an effect. And quite frequently you'll find that fluid challenges aren't done as you'd expect, or by the time the fluids have gone up and everything like that, and you need to just make sure you're aware, because it's quite easy to then get distracted by another patient. And I guess then you can do all the initial stuff, but you need to escalate as appropriate. So some people will need arterial lines or central venous pressure monitoring, and they'll need to go to ITU, or they'll need dialysis because they've gone into AKI. And as it just we've covered this already really. ADG is really important, particularly for sepsis, to get your lactate. You can sometimes do venous gas, that'll be absolutely fine, but if you're at all concerned about their ventilation, do the ADG. And it's quite a reassuring investigation as a house officer doing an ADG, because it sounds awful, but you feel a bit happier when their gas isn't as bad. And then things like chest x-ray and bloods we've already covered, and then obviously if you think someone's got tamponade, you'd need to get someone to do an echo. I won't mention too much about drugs because you're not, we're not going to give them basically. It will be ICU. It's just something to be aware of. So if you're giving someone fluid after fluid and it's not having an effect, or you're having to resort to a lot of fluid, then they really need their central venous pressure monitoring, and they might need some vasoconstrictors like noradrenaline, and then inotropes for reduced cardiac output. But again, this is the sort of thing that would be more intensive care or senior-led. So now we're going to go on to talk a bit more about sepsis. Okay, and this is really frequent, so you'll see a lot of this. And we have to talk about SIRS, so systemic inflammatory response syndrome, and you need to know this, I'd say. So you need to know this criteria. So you have to have 2 or more of either pyrexia over 38 or temps below 36, heart rate over 90, so it's not even over 100 on this criteria, it's over 90, rest rate over 20, or PaCO2 below 4.3, and the white cells either raised or low. And it's actually quite easy to fit those criteria, I'd say. But you obviously can get SIRS from pancreatitis and other things, so it's not just sepsis and infection. And then if we work our way up this, so you've got SIRS there at the bottom, and sepsis is when you've got SIRS plus evidence of infection. So if you've got someone with symptoms of a UTI or a positive urine dip plus SIRS, then you'd say they're septic. severe sepsis is when you've got that, but you've also got some evidence of end organ damage. So either their kidneys aren't working properly, their urea and creatinine have gone up, or they've got low BP, or they've got respiratory problems, like drop in stats or increased respiratory rate. If they're confused, then you know they're not, and they're newly confused, you know they're not perfusing their brain, and that's end organ damage. And then septic shock is when you've got that, but when you've got sepsis that is resistant to fluids, well, not resistant, but say you've given someone a fluid bolus of 20 mils or 40 mils per kilo, and their BP still, their systolic still below 90, or their mean arterial pressure is below 65, or if you're in the fortunate position of knowing their baseline and it's still 40 below their baseline, then that's when you call it septic shock. So it's important to be aware of those definitions as well. And initially when someone's septic, and if you see them early, then they're often quite warm and they've got this bounding pulse. But later they might not be warm because they've got worse. Whereas initially they're all vasodilated, they feel quite hot, they might have a temperature. And then, as I was saying before, it's to do with increased vascular permeability as well as the vasodilation. And they're not always pyrexial, especially older people. They might not have that same response to infection. And then you've also got immunocompromised people who might not be able to instigate that same response as well. So the management is pretty similar to what we've already covered, so I'm not going to go too much over it, but obviously it's important to get that venous gas or the ABG, so you've got a lactate, and urine output is particularly important in sepsis, and you need to try and find your source, so try and think about where it's coming from. So many times people blindly start antibiotics, which is fine if people are really unwell, but microbiology aren't especially happy when no one ever did a urine or they didn't get that chest x-ray. normally chest x-rays are done, but often the urine's missed. Or is there anything else that's causing it? Have they got cellulitis? What are their lines like? All those sort of things. And if you can try, I mean, you know all this, but try and get the cultures first, but if you can't get the cultures, then don't delay treatment. And then initially, it depends on where you think it's coming from. If you know it's the chest, then you go with the guidelines, but if you're not sure, then you might have to start broad spectrum antibiotics and then narrow it down once you've identified what's going on. And I guess some causes of sepsis, like abscesses, aren't really going to get better unless they're drained. So these are flying around the hospital for all sorts of things, but the septic fix is basically, if you can remember to do that as an F1, then they'll be happy. And you've probably seen all the packs around the hospital. Have you guys seen those red bags? The buffalo bags? Like, they've got everything you need to do really. In the culture bottles there in Leeds, we've got these red bags that actually have this written on the front, I think, and inside the stickers that you stick in the notes to say, as you do everything. So these are the septic six, and this is what you need to remember, and it's what you need to remember to do as a health officer. So blood cultures, urine output, fluids, antibiotics, the lactate, as well as other bloods. It's important to get a HB as well as all the other ones, and oxygen. And then the Surviving Sepsis campaign extends a bit further, but this is probably less relevant to you, but in terms of what's expected from perhaps a more intensive care point of view as things go on and don't get better, such as having vasopressors and having central venous pressure measurements and things like that. You also need to be aware that you look for other problems as a result of sepsis. So what's their renal function like? Have they got worsening acute kidney injury? Have they gone into DIC? And again, this is probably more specific for ICU type things, that they try to maintain their central venous pressure around 8 to 12. And as I was saying, if you're having to pile someone with loads of fluid, then it's good to have an idea of what that is, rather than perhaps just completely overloading them. And urine output, I mean, I don't want to teach you to suck eggs, but when you're a health officer as well, knowing that is useful, so that it's not necessarily the 30 ml cut-off at 0.5 mils per kilo per hour, because you will get little 40 kilo ladies who you'll be asked to say, like, see because their urine output's reduced, and you don't want to be going for whacking loads of fluids in them and overloading them if their urine output's actually 20 mils an hour, and that's absolutely fine for them. In terms of complications, so you can get acute respiratory distress syndrome, circulatory failure, as we talked about, AKI, and DIC. And the mortality for severe sepsis is quite high, so I don't know whether that's just for I don't think that's just for ICU, I think that's in general. And obviously if people are older and they've got lots of comorbidities, then their outcomes are worse. So let's do a few practice questions to finish. So you've got an elderly gentleman who presents to A&E with a 2-day history of cough and with green sputum. Observed, he's got a temperature of 39, he's tachycardic at 120, his GP is 80/40, his respiratory rate is 30, and his stats are 90% on air. On examination of his chest, he's got right basal crackles. What would you say best defines this patient's condition? What would you... Severe sepsis, did you say, or sepsis? Definitely. So I'd say, I mean, it's a slightly grey question, but I'd say it probably falls under severe in that his circulatory system's been quite significantly affected by it, which sort of suggests end organ damage, and so is his respiratory system, although he's got a pneumonia. If they said he was confused, then I'd say that would seal it. We can't say here that he's in septic shock, because although his BP is 80/40, he's not being given any fluids, so can't really comment on that yet. What is your first step in managing this patient? Yes. Always remember A, B, C, D, E. I know you'll get it drilled into you time and time again. Yeah, so oxygen. Because when you go into your OSCEs as well, you'll be nervous and you will panic, but if you think about ABCDE, then you'll be absolutely fine. And I know you guys have scenarios that are a bit more want you to do that kind of thing. So yeah, that's good. What's this? Anyone want to shout it out? Yeah, meningococcal septicemia, so you don't want to miss that one when you're exposing the patient. What antibiotics would you give? Sorry? Yeah, so ceftriaxone, ceftriaxone, obviously the specific guidelines that tend to be along those lines. You were called to see Mrs. Jones. She has become acutely unwell. Her obs are respiratory rate 30, heart rate 106, BP 86/54, stats 92% on room air. On auscultation of her chest, she's got muffled heart sounds. This is her chest X-ray. What does it suggest? Yeah, so it looks like pericardial effusion on her chest X-ray, but she's also been affected by it. So it would suggest that she's got a tamponade. What type of shock is she in? Good. Cardiogenic. Mr. Taylor has become acutely short of breath. He's clammy, sweaty and peripherally shut down. Breast rate 35, stats 90% on room air, BP 90/60. What type of shock? It's a bit difficult. What kind of does that sort of description? What sort of comes into your head? Yeah. So you'd probably be thinking about pulmonary edema, acute pulmonary edema, which is cardiogenic. What does his chest X-ray suggest? I don't know if it's the best example, but sorry. It's more meant to be LVS sort of pulmonary edema, but it's a pretty rubbish-looking chest X-ray anyway, and I wouldn't be surprised if you treated him for infection and all sorts based on that. Just a quick bit of revision of knowing the signs on the chest X-ray for cardiac failure, and they normally have that A, B, C, D, E thing in the Oxford Handbook, which I don't always find helpful because you're meant to remember alveolar edema, curly B line, cardiomegaly, diverted upper lobe, and then the effusion. But one thing I guess it's worth noting about sort of someone in pulmonary edema. Has anyone seen anyone in pulmonary edema? Yeah. What do you think you'd recognise it again once you've seen it? Yeah. So I unfortunately didn't see it until my second week of being an F1, and I think once you see it, it's something you won't miss it again. They'll be holding. People always say it in books, but when you see it, it just all comes to light. Like they'll be holding onto the rails, they'll be sweaty, they'll be clammy, they'll feel cold, and they'll be coughing away there. And I remember being bothered about getting an ABG on this woman, and my SHO came along. He was very helpful. He was like, "That is pulmonary edema," and once you've seen it, you'll know it when you see it, basically, even before you've listened to their chest. And how would you manage this? Just a quick bit of general finals revision. What are you going to give them? Oxygen, yeah. Yeah. What dose would you give? Yeah. Would you give it IV, oral? Yeah. Of which diuretic did you say? Fusimide. And remember, fusimide, and it's not the diuresis effect that initially makes them feel better, it's the venodilation. So it's also worth giving them, as long as they're not going to go into respiratory arrest, a bit of diamorphine, 2.5 milligrams. It will help them feel better. And GTN if their blood pressure's okay. In this person, you'd probably be a bit wary about giving them GTN, probably seek a bit of senior advice. But if their blood pressure's over 100, then you might start a GTN infusion or give them a couple of puffs of GTN. And when you treat someone in pulmonary edema, it's quite good because they suddenly feel quite a lot better. So final few things. You're asked to review this rash. What type of rash is it? It's not the best image, but if they looking a bit rare, it doesn't look especially convincing. But within the context of shock, yeah, urticarial. It's not a especially good example. Urticarial tends to be a bit, particularly on the chest, quite raised, lumpy, red. She started to look more unwell and had some difficulty breathing. Respirate 30, stats 93% on room air, BP 100/60, heart rate 110. On auscultation of the chest, she has stridor. How will you manage her? Sorry? Yeah, so you do A, B, C, D, E, but what are you going to give pretty quick? Yeah, adrenaline, and that's the most important. Out of all the treatments for anaphylaxis, it's the adrenaline that's important. And what dose do you give? Yeah, 0.5 milligrams, and it's the 1 in 1,000. It's not 1 in 10,000, and still quite frequently it does happen at arrests that the wrong strength is used. So make sure you remember that arrests is 1 in 10,000 and anaphylaxis is 1 in 1,000. What else will you give them? Chlorphenamine, how much? 10 to 20 IV? And what else would you give? Steroids, yeah, so you could, if they're not going to be able to swallow, which it sounds like she won't be able to, then you'd give hydrocortisone, probably 100 to 200 milligrams IV. If someone starts having circulatory collapse, then you might be putting their legs up and things like that, but you have to be careful that you don't cause them airway problems. So if they're sat up and breathing, then probably don't do that. But a few general tips, mainly for the off-ski, is it's quite good when you get nearer the time, because I know it's early days for you guys yet, but get into groups and go through scenarios, brainstorm them, help each other, because it will make it a lot better. Don't worry about what everyone else is doing, just concentrate on yourself, and everyone will have different areas of expertise, so maybe don't get freaked out by it. And they're basically looking for safe F1 doctors, so I think Leeds seems like a very practical university, and they're definitely just looking for you to be able to be a safe F1. So remember, the most important thing about shock is recognising it, learn first, know the septic fix, and don't forget ABCDE. Does anyone have any questions? There's references, and now I need to remember